When we talk about consent, what do we mean by consent? And usually when we talk about consent, it means that is a communication between a patient and a physician that results in patient authorization. In other words, it can also mean that there is an agreement to undergo a specific medical intervention. Now, assent is little different from consent. Okay. When you say assent means you agree for the procedure, you do not know whether it is good or it is bad. Whereas when you give consent, you understand the consequences of your action, whether it is good or bad, and then you give a consent. Understood? This is the basic difference. When you say assent, you agree for any procedure. You are not capable of understanding whether it is good, bad, or what is going to happen with that procedure. So, a child below the age of 7 years is totally cannot understand what is happening to it. From the age of 7, from philosophical point, it is understood that the child will be able to discriminate what is good, what is bad. And as the child grows up in age, the discrimination keeps increasing. Just because a child becomes 18 does not mean that child can discriminate. Now, if a child is celebrating birthday tomorrow, today he is not able to discriminate, tomorrow he is totally able to discriminate. Okay. So, this concept has to be understood. The legal term of 18 years is 18 years, but the maturity at which you judge may be different. We have the concept of a mature minor. Okay. If a person can understand the consequences of the action, it is for the court to judge whether you are able to understand the consequences of your action, and the child is considered to be a major. Like for example, a child who is a teenage mother who refuses to undergo an abortion, but the parents want to take abortion. This was a case in the Supreme Court where the decision went in favor of the teenage mother because she understood the consequences of conception. Okay. So, this is a very important concept that we need to understand. Now, when we talk about consent, why do we need consent? It is a legal and ethical reason. Okay. In medicine, when you talk about medical ethics, there are some parts of the topics in medical ethics where most of the discussion is on a ethical framework, and there are some parts of medical ethics where most of the discussion is on a legal framework. When it comes to consent, there is one place in medical ethics where both legal as well as ethical issues agree on point. Okay. Then consent is also necessary because it minimizes potential harm to the patient. Like for example, if without a consent you give a drug and the person develops a side effect of the drug, he will not come and report to you. So, it becomes essential that you take consent so that you can protect from potential this thing, and it avoids unfairness and exploitation, and lastly it protects the patient's rights. Okay. These are the reasons why we need to take consent from the patient. Now, advantages of consent in a clinical setting is it improves doctor-patient relationship. It clarifies what are the objectives of treatment and gives a framework for the doctor to act. And lastly, patient may cooperate fully with the treatment. In fact, when I was preparing for this lecture, I read a thing is olden days before anesthesia came about, patients were explained what was being done so that they will bear the pain better. And that is how one of the ways consent became a very important aspect of doctor-patient relationship. Okay. Next, when we talk about ethical basis of consent, there are three things that we talk about. One is on the principle of autonomy of the person. Okay. Consent is necessary because we respect the person's autonomy, that is liberty, and the capacity for intention and action, that is the agency. And respecting autonomy of person is to minimally acknowledge that the person has a right to hold views and make choices, and to make choices based on personal values and beliefs. Okay. So, autonomy means that you are able to make your choices on personal values and belief systems, and you have a right to hold your own views. This is where the conflict arises. The doctor says you do this and the patient says no, sorry, I do not want to do this. Then you say this patient is a very bad patient, he does not listen to what the doctors say. But remember, we need to handle the autonomy of the patients as much as possible. Then, and when we need to respect autonomy of a person, we look at Kant. Kant said all persons have unconditional worth. Each person has capacity to determine his or her own moral worth, and it is the basis of treating persons as an end in itself, not as a means to an end. This is one of the basic principles of Kantianism. When you talk about utilitarianism, which is again the philosopher Mill talked about, society should allow individuals to develop according to their convictions as long as they do not interfere with the expression of freedom by others. Now, rights is what we always talk about very often these days, and now the predominant bioethics that we talk about is based on rights. And in 1914, the Supreme Court of America decided that every human being of adult years and sound mind has a right to determine what shall be done with his own body. So, this is the ethical principle or the legal principle that goes behind the consent. Now, when we come to the legal basis, there is consent comes on battery, which is liability is imposed for permitting touching, and negligence. And today, most of the legal questions that arise in consent are in relation to negligence. When we come to the Indian Penal Code, there are 4 sections that deal with consent, which is essential. Act, that is section 88, act not intended to cause death done by consent in good faith for the person's benefit. Act done in good faith for, that is the protective act that you have when you enter in emergencies. Act done in good faith for the benefit of a child or insane person by the consent of a guardian. Consequent defense when there is not known to be any likely cause for death or grievous injury. Excludes requirement of consent for an act done for the benefit of a person. So, these are the 4 sections in the Indian Penal Code that talks about consent as an important requirement. Now, when we come to the Medical Code of India, it says 7.16, before performing an operation, the physician should obtain in writing the consent from the husband or wife, parent or guardian in case of a minor, or the patient himself as the case may be. In operations which result in sterility, the consent of both the husband and wife is needed. Okay. Now, the first part of it we all practice. Do we practice the second part? Do we obtain consent from the spouses when you are doing family planning operations? No.
It is mandatory. I mean, it is just done. It doesn't really.
No. According to the government, this is the problem. See, in our country, the medical council will talk something, the government will talk another thing. According to the Government of India Act, the person undergoing the family planning operation is the one who has to give consent for the surgery. It is not the husband or the family or anybody. Okay, that is why they talk about vasectomy camps, tubectomy camps, where people can just give consent and get the surgery done. Okay, but this is this thing it says about. Then the second point that medical code talks about is in relation to publishing photographs and clinical material, case reports. Previously, those of you who have been following medical journals, about 10-15 years ago, there was no permission required to publish a photograph or a case. Nowadays, if you go, especially international journals like BMJ, if you look back the issues where they release interesting cases or photographs, there will always be a statement saying permission was granted by the patient for this publication. So, the same thing has been incorporated into the medical council code for consent. Then, how much of information to give also is mentioned in the medical council. It says a physician should neither exaggerate nor minimize the gravity of the patient's condition. He must ensure himself that the patient, his relative or his responsible friends have such knowledge of patient's condition as well as serve the best interest of the patient and the family. So, almost most of the codes that you see always talk about the individual patient, but here is one place where you say you not only talk about the individual, but you also have to include the family in the decision making. Okay. Now, what are the elements of consent? There are 3 major elements of consent. One is the threshold elements that are necessary, that is, person should be competent to give consent. Second thing is consent must be voluntary, and the third this thing is informational content element that consists of disclosure, recommendation and understanding. See, this is important to understand. As a doctor, it is not just giving all the therapeutic options and telling the patient you choose. You are bound to give a recommendation. Okay. and you must see that the patient understands what recommendation you give. Patient may not agree with what you say, then you have conflict. Then we have decision making. The patient decides to undergo surgery and he authorizes you to undergo surgery. That is where you take written consent. Okay. So, these are all the different various aspects when you talk about consent. What do you mean by competence? When you say capacity or ability to perform a task, okay, and competence can vary, okay, and competence varies from context to context. Okay. I may be a good talker, but I may be a lousy writer. Just because I talk does not mean I am a competent writer. Okay. I may be a lousy car driver, that does not mean that I am very competent to drive a car. So, it varies from context to context, and usually competence is specific, it is not global for anything, and competence may vary over time. Okay. And now, there are different standards that have been applied for competence. What I would like you to look at is the competence is judged by 5, 6 and 7. Inability to give a rational reason, inability to give risk benefit related reasons, inability to reach a reasonable decision. When patients make these type of things, then you consider that they are incompetent, not because they do not agree with what you say. Okay. Now, we always work on the presumption that every adult is competent to decide what he has to do. Okay. And if the patient's choice appears irrational or does not accord with the doctor's view of what is the patient's best interest, that is not evidence in itself to say that patient is incompetent. And if there is a question of incompetence, we need to refer to a second person or a psychiatrist to assess whether the patient is incompetent or not. Now, I will give you this story. Mahesh is a 33-year-old man. He is mentally incapacitated. He is being looked after by his only sibling Rajesh, a police constable. Rajesh is sole breadwinner of the family. He is suffering from chronic renal failure and he needs a transplant. The only donor available is Mahesh. His mother agrees to donate his kidney for his brother Rajesh. Is this justifiable? See, the point that you have to think here is how incapacitated is Mahesh to decide. If he is totally incapacitated, then the mother has a right to give, to agree for it. But if he has capacity to decide whether he wants to give his kidney or not, we must respect Mahesh's decision. The whole controversy on this transplant was this. The family thought he is not capable of deciding, psychiatrist thought he is capable of deciding. This is the crux of the problem in this case. Okay. Ultimately, he did not donate the kidney. Okay. Now, we talk about surrogate decision making. Okay. Are persons who make decisions for incompetent patient, and usually a quality of surrogate decision maker is commitment to incompetent person's welfare. That is very important. Second is the ability to make a reasoned judgment, adequate knowledge and information, and must be emotionally stable. Now, the surrogates become very important when you are dealing with patients, especially when you are dealing with people who are mentally incapacitated or people who are living alone, who do not have an immediate family. This happens very often when you have the family abroad and the parents staying here. You know, one of them will be there alone, living with his friends and things, and if something happens, somebody has to take a decision. And by the time the son, who is supposed to be a legal person, comes from America or wherever he is, decisions have to be made. So, you need to look at surrogate decision makers as an important aspect. Then, when you say voluntary, a person is said to be acting voluntarily if decisions are made in the presence of adequate knowledge, absence of psychological compulsions, absence of external constraints. Okay. Now, you can influence the person making decision either by coercion, persuasion or manipulation. And usually coercion is intentionally uses credible and severe threat of harm or force to control another person. That happens very often. You will say, if you do not undergo this procedure, you will die. It may be true, but it is a form of coercion. Okay. Persuasion is, see, this person, he underwent this surgery, see how nicely he is living, you will not have any of these problems, and you persuade him. Like for example, when you have to do a colostomy for a patient with cancer of the colon. Okay, it happens very often. Patients may refuse a colostomy, then usually you have the colostomy club members going and talking to the patient and trying to do that. And when these two things don't fall in, it calls into manipulation.
That means communication is not possible. I mean, it will be a bland exchange of facts, period. Is that all that a doctor is expected to do were he to go for the legal and ethical cover? I don't know if I made myself clear, sir.
No, the last part you did not make me clear.
No, I said if all that we generally say is going to be construed as coercion and persuasion and things like that, what we will be left with to convey to him is mere facts. See, you have an LAD block, LCH,
I agree
right?
with,
all that.
now I got your point, what you are
Right.
trying to say.
Yeah.
See, what I am saying is, we will, and part of practice, we use influence.
We do.
We do use influence, okay, but we must acknowledge that we have used influence. Okay, see, because aware of what is happening, because most of you, I don't think till I put this up, nobody had thought that this could be a kind of influencing people. Okay, this is the idea behind this whole thing. Now, when we talk about voluntary decision making, usually the decision is for the patient, not the doctor, and patient to decide what is in his best interest. This is a very tricky situation for those of us who are brought in a paternalistic mold. I say, so you must do it. And here we are talking of democracy, where patients have to decide what is best in their best interests. Okay, we should help them to reach their own decision. Now, what are the core sets of information that you give when you are talking about informed consent? So, we must give facts that are material in deciding to consent or refuse an intervention, information that a professional deems it as necessary, and you must also give what is the purpose of seeking the consent, nature and limits of the consent that you can do. Okay. Now, when you talk about standards of disclosure, there are 3 different standards that have been used. One is the professional practice standard. Okay, when you are doing research ethics, the consent form will contain all the possible known side effects of the drug or the intervention. But in clinical practice, nobody can talk about all the possible side effects of the procedure that you are undertaking, because it is just not humanly possible that every side effect can be told. So, the judgment that will, if you are sitting in the consumer protection court, would be to understand what is a professional practice. If everybody says if you take anticoagulants, you are likely to bleed. So, if you have bleeding, come to the hospital, that is taken as a professional standard. Okay. Or the other point is, if you have to maintain your internal INR ratios between 2 and 3, is a professional standard that you are informing the patient. Okay, he may do that, and he may find that it has come to 6 and he knows that it is danger and he has to come to the hospital and get treated. The other one is to apply what is known as a reasonable person standard. The amount of information that is to be given is determined in reference to a hypothetical standard subject. Okay. This is where we in India try to manipulate. He is an illiterate person, so he does not know that much what the importance is. So, I will just tell him, if you have some bleeding, you come do this test. If the doctor, the lab tells you to come and see me, you come and see me. You worm your through to. And the third one is subjective standard, where you only take into consideration how much the subject can understand and talk about it. Okay. Okay. Now, when we respond to questions, it is very essential that we should respond to every question honestly that the patient raises. Okay. And sometimes this can be very difficult, accurately and objectively as much as possible. Okay. Now, doctor providing the treatment should obtain consent. When this is not possible, it should be delegated to a person who is suitably trained, qualified, has sufficient knowledge of the treatment and understands the risks involved. Okay. In practice, what happens is, very often just before the patient is wheeled into the OT, the nurse or the aide takes a signature. and that will be a blanket statement. I have been explained all the risks of this surgery, and I understand that I may have anything under the sun. I don't have this thing, and that is the wrong. It should be somebody who has been trained. So, either a doctor or a junior doctor or a trained nurse who has worked in that department for a long period of time, who understands what has been, is the person who should take this thing. And doctor has to ensure that before any procedure, the patient has been given sufficient time, information to make a informed consent. Okay. And very often you will see some of the surgeons who will go to the patient in the theatre before he is being induced, tell him about the operation and say, shall we do? That is one practice that many surgeons have. They will go and talk to the patient before the patient is being induced into anesthesia. Now, when we talk about different forms of consent, express consent is what patient indicates the informed consent either orally or in writing. Implied is by the way you behave, the consent. The way the patient gives the hand for examining the pulse implies that he has permitted you to examine him. Okay. So, implied consent is something, and tacit consent is consent which is can be silently or passively by omission, and presumed consent is we decide that the patient would have given us consent if he knew what this was. This happens in emergency situation, like for example, cardiac arrest. You are going to resuscitate the patient. You presume that if this person knew what was happening, he will give you permission to resuscitate. Okay. Deferred consent or future consent is not acceptable ethically. I can't write, if in time that happens, this is the consent that I give for this procedure. Okay. Now, here is another patient, Mr. Raghu, brought to the casualty with chest pain. As he was being examined, Raghu develops cardiac arrest. CM, the casualty medical officer, instituted cardiopulmonary resuscitation. Raghu developed fracture of 2 ribs, and also he developed burns over the chest due to defibrillation. Raghu was shifted to ICU. Did the doctor do the right thing? Okay, he did it right. Okay. Now, there are certain areas where you waive of consent, and one of this is an emergency. Okay, you presume that you are doing it in the best interest of the patient. The second area where you have is advance directives. Unfortunately, in India, we do not have legally give advance directives, whereas in the West, you can give advance directives. That is something like a will you write, say that if I am incapacitated, I cannot decide for myself, I would not like to be on a ventilator, or I would not like to be dialyzed. I would like to inform so and so to take decisions on my behalf if I become incapacitated. So, these are known as advance directives, and here also there are areas like, suppose there is a Jehovah's Witnesses. Jehovah's Witnesses are a group of Christians who believe that you should not use blood for any reason. Okay, so they will not allow their members in the thing to receive blood from for any therapy or blood products for any therapy. So, in an emergency, the doctors are put into a lot of difficulty if there is a Jehovah's Witness, but we need to honor their decision making. Now, the question comes is, what about suicide notes? The patient says, I don't want to live, I am killing myself. Will you resuscitate this patient or not resuscitate that patient? Usually, you don't accept the suicide note as advance directives because you presume that person who writes a suicide note is mentally sick. He is not in a capacity to decide. Okay, not because of law, it is because of this. Okay. Where the consent can be waived is when there is an order from the magistrate to examine, whether it be a criminal case, whatever the case, if you have a court order saying that this person has to be examined medically, you can waive off the consent. You do not have to ask the patient for his consent, you have to examine the patient. Okay. The third last one is physical restraint. You have a very violent patient. You cannot go and tell him, Baba, I am going to put handcuffs on you and tie you to the bed because you are violent. Okay. You do it. Okay. So, in a violent patient, it is a harm for himself as well as to the society. That is why you waive off the consent in this. Now, the question of prisoners is another area where consent becomes a very tricky issue, because if he is an unconvicted prisoner, under trial prisoner, he still has the rights to choose to give consent. Okay. But if he is a convicted prisoner, he loses autonomy. Okay. So, he does not have a choice of doctor or the hospital. But even then, only the British Medical Association makes a comment saying,
Sir.
you,
Is he not a human being?
pardon?
Is he not a human being? Because
he's
he's convicted does not mean that he cannot
No.
be.
When we talk about it, that's a big discussion. Okay. After we finish this, we will talk about prisoners and human rights. Okay.
Okay.
Because when it's only 35 minutes I have. Okay. So that's a good point that you have brought, because prisoners is this. Only the British Medical Association makes a distinction saying a patient may not have a choice of, a prisoner may not have a choice of choosing the doctor, but the doctor still has to get consent before doing procedures on the patient. Okay. Now, certain areas consent to procedures that may not be of interest to the patient. Like for example, organ donation from live donors. Okay. Here, why should a person who is rational donate his organ? What is the consent behind this? Here you think of altruism. Similarly, when you ventilate a brain dead patient, to harvest the organs. Okay, the minute the patient is declared brain dead, organs are not harvested. They will find a suitable recipient and then only harvest the organs. Okay. So, here again the question comes as, who gives consent for this thing? And we have the laws which permit the next of the kith and kin to give permission for that. Procedures on dead patients. This happens very often in medical schools. Your patients, before the mannequins came about, at least I learned intubation by doing it on dead patients. Okay. And there are certain procedures which patient will be there. Previously, we never used to ask permission from the relatives or anybody. Screens used to be drawn and it used to be done. But now, we need to get permission from the relatives before you do this type of procedures on dead patients. Okay. There are certain areas which is again with lot of controversy for special treatment. Psychosurgery. Person is very violent, or for example, is a sexual offender. Okay. Either you can castrate him or you can knock off his frontal lobes. He is a danger to the society, menace to himself, so you are providing this thing. It is a very dicey situation, because there are some courts which have allowed this type of surgery to be done on patients who are sexual offenders. The second thing that has happened in our country is also hysterectomy in mentally challenged women. Okay. Why not tubectomy? Why hysterectomy? Because the point that they talked about is, it is very difficult for a mentally challenged woman to have menstrual hygiene, and it is difficult for caregivers to take care of it. So, in Pune in 1995, one of the mentally challenged homes, one of the mothers went and asked to have a hysterectomy done on her daughter, because she said, every time she menstruates, she is making a mess of herself, and I do not know when she can get pregnant, because I cannot take control of her. She asked for a hysterectomy, and there was a hue and cry. Ultimately, Sharad Pawar was the chief minister at that time, and he put his foot down and said, yes, what the mother says is right. Hysterectomy will be done, and it will be done in the government hospital. Okay. Fertility surgery is again another issue, where certain types of surgeries, sterility taking place, you need to get consent from the spouse. But because of the ruling that is there in the family planning on the government of India, it does not apply so much in our country. And lastly, paternity testing. Okay. Whose interest are we serving when you do testing a paternity? It is not definitely the child's interest. Okay. It is that there is a dispute, conflict or dispute between the parents, and you are trying to test the child. So, when it comes to this type of thing, you must have a court order before paternity testing can be done. Okay. Then a written consent is preferable before we do any procedure is performed, and if the data is used for studies or audit, and by the medical council code, all surgeries should have written consent. Okay. Then consent form should detail the key elements of the discussion for the patient, including the nature of information provided, specific requests by the patient. Details of the scope of consent given should be recorded in a consent form. It is not just the standard legal wordings that matter. it's a procedure that matters. Okay. And consent can change over time, and as long as the patient does not have, patient gives a consent for some surgery, as long as the patient or some procedure or some treatment, as long as the patient does not object, consent is valid. The minute the patient objects to the treatment, then the consent becomes void. And at that time, we need to decide whether the person is acting autonomously, is the change consistent with character, or is the person competent. Okay, this has to be decided when the person wants or withdraws from the treatment. Okay. And just because we have a written consent, it does not mean that it is foolproof. Okay. So, we need to discuss with the patient and change the consent as and when we need it. Okay. I shall stop here. Any questions?
Yeah, this is actually related to that mentally challenged woman. Can family members really take such decisions to do hysterectomy in mentally challenged cases?
No, she went to this thing. See, these are things that take place like that. There was somebody in the hospital or the NGO who decided that it is not the right thing to do, and he approached. If that person or that organization had not approached, somebody, they would have just gone underground.
But
So
then
needs
it
to
was
be
allowed,
embraced.
you're saying. You're saying that it was allowed.
Sharad Pawar, after discussion, agreed to it.
But how can he decide?
Pardon?
Doesn't it have
He's
to
the
go?
chief minister.
He has to go to court still, isn't
Pardon?
it? Doesn't it have to go to court still?
Not necessary. If this thing, unless somebody challenges in the court, it will not go to the court. It did not go to the court as far as I know.
So, do not the prisoners come under the category of vulnerable population, and when they are involved in research?
In research, different question. Okay. They are still vulnerable because the government cannot go and say, no, you fellows are there, we will ship you all to somewhere in Saichen Glacier, you will cut ice and make road. They cannot do that. Yes, sir.
There are special prisoners, like the president or the senator or House of Representative member. What about him if they take him to the hospital?
Yeah. No, see, even that's a good point that you have brought. Even in the prison, there are different classes of prisoners where the privileges are different. And that I'm not an expert to tell whether it is right or wrong, but it's there in the manual, and according to that manual, the prison authorities will act.
Yeah, because there was a prisoner who is a governor, and he was out of they take him out of the prison and take him to Dubai for special treatment. Why don't they treat him in Nigeria? Yes.
Yeah,
You
those
see?
things happen. Some are more equal than others. Everything is not always there, no?
Then I think the prisoners have opportunity of saying this is what they want and this is what they don't want.
No, but
In that case-
the problem is the law doesn't allow them to decide that. You know, there is no democracy in the prison. Your timing of getting up is marked, your time when you are going to bed is marked, time you can exercise is marked depending upon what you
So
fall
I
into
think
category.
if we keep on talking, we can keep on talking about this thing, because still I think there are some special prisoners who have special right of choosing what they want and what they don't want.
I agree with you. That's all part of the system.
So I have two questions. First one is regarding the Code of Medical Ethics. Code of Medical Ethics, it's a part of statute and
Yeah.
we are bound to abide by that.
Yeah.
So according to that, we have to get consent from both the partners in the case of
See,
sterilization.
this again, no, when there are
So
two laws.
I am about to ask whether, according to the hierarchy of legal source, which one comes first? The Code of Medical Ethics or the other rule?
See, when you talk about Code of Medical Ethics, the problem with the Code of Medical Ethics in India, I do not know whether the first Code of Ethics was first drafted in 1956 based on the British Code. It was not gazetted till 1970, and according to the history, this was being discussed in various places, and it was gazetted it. And in the Code of 2002 was finalized in a period of 20 days. The Supreme Court said the code has to be changed, the code was changed. Okay. Unfortunately, at that time the health minister was C.P. Thakur, a physician, so he put on whatever he felt was the right thing to do in the code. See, like there is one code which says if the doctor in the PHC is found for 15 days, whenever somebody goes for inspection is not found in his place for 2 consecutive times in 15 days time, action can be taken by the medical council. Okay. When you have systems in place for PHC doctors, why should it be in the medical council? Okay, there are a lot of stupid things that have crept into this, and this is one of the things, the ambiguities that has gone in. So if it has to come, nobody has challenged it. And as I talk about the beginnings of life, there is another one statement which again is like this. Because nobody has challenged it, we still follow what the government says.
Okay.
Okay. When the government order comes, it's also gazetted, it becomes a part of the law.
Second question is regarding therapeutic privilege. I don't remember exactly where I read.
That was
So
a
an
old concept which was there before we talked about informed consent. Therapeutic privilege was the privilege that the doctor had, that if he broke a news, patient will feel depressed, patient will feel sad, so the therapy will go down. So he would not tell him. So for example, if you give chloramphenicol for typhoid fever, you know it produces agranulocytosis. You will not tell the patient it may cause death. Say, very good drug, you take it. Because the feeling is, if you tell him that it may produce a side effect, patient may not take the tablet. Okay, this was known as therapeutic privilege, but now in the current concept, this is not accepted as part of medical care.
Sir, for taking the informed consent, are you using printed forms in your hospital?
We use both.
Okay.
We use both. It depends mainly on the type of surgeons and the people who do interventions. Some surgeons, there is a general consent form which is there. They're saying that no, it has been explained to me in my language that is known to be understood by me, and all that things that is written, which is printed, they sign when they join the thing. But for every procedure, many of the surgeons take a consent from the patient after explaining what has happened.
Okay.
And
So
there is another problem. The person who signs the consent form as a witness should be a third party. You know, some other patient's bystander. If you ask the staff nurse to sign, tomorrow when you go to this thing, they'll say you have fabricated the consent. Consent is you talk to the patient in the local language, but the writing is in English.